practical examination. Okay. So first, what is the definition of the pregnancy-induced hypertension or preeclampsia that you have to know? That is about should be defined. High blood pressure recorded after 20 weeks of pregnancy and 4 hours apart. Then pathophysiology, clinical presentation, decision making very important, and monitoring and management, pre-op investigations, delivery management, complications and management. And these are the headings in which we discussed. And out of the allied topics, sometimes the completely omitting pregnancy-induced hypertension, they can ask you all about the anatomy of the pregnancy, the female reproductive organ. They can ask you about the physiology of pregnancy. They can ask you about other allied topics. So, hypertensive disorders are one of the most common medical problems associated with high mortality of both mother as well as the fetus. It is a new onset hypertension. That is a very important terminology that we have to include. New onset hypertension after 20 weeks of gestation, classified into 4 categories: preeclampsia and eclampsia, onset after 20 weeks, which is associated with proteinuria. Then there is a gestational hypertension, which is not associated with proteinuria, but that also happens after 20 weeks. And chronic hypertension, which has been there even before 20 weeks or even before the mother became pregnant, or it can be a chronic hypertensive patient who becomes pregnant and on her there is a superimposition of preeclampsia. So onset of blood pressure is before 20 weeks, but later on she develops proteinuria. Then you have to combine these 2 conditions, which is called chronic hypertension with superimposed preeclampsia. And pre-gestational hypertension can be one of the following: can be a primary or secondary hypertension, it can be a white coat hypertension, or it can be a masked hypertension. All the 3 conditions we have already discussed and I told you. And the extreme degree of this hypertensive pregnancy condition is called HELP syndrome. It is a variant of eclampsia where it may be associated with hemolysis, elevated liver enzymes, low platelet count. And this term was coined by Weinstein in 1982. And pathogenesis, it is a 2-stage process. Preeclampsia, why it happens, it is described in 2 stages. The first stage is the abnormal placentation. Placenta is not getting properly implanted after the maternal residua of the maternal wall. So the vascular remodeling does not happen properly. It results in, because of the maternal factors like genetic, behavioral, and environmental. And the stage 2 is the maternal syndrome of preeclampsia. The main thing happening there is the endothelial dysfunction. So in the first stage, it is the improper implantation of the placenta. In the second stage, it is the endothelial dysfunction. So the maternal syndrome of preeclampsia characterized by decreased perfusion due to vasospasm, because the spiral arteries have still got the muscular coat, which is not removed. So from resistance vessel, it has to become a capacitance vessel. It has to accommodate blood, whereas it doesn't lose that muscle coat, so it remains still vasospastic. And there is an activation of coagulation cascade with microthrombi formation, which also causes end-organ damage. So the resulting endothelial dysfunction produces a main imbalance between pro and anti-angiogenic factors. That is, new vessel formation is affected. And the angiogenic imbalance is because of the balance between the vascular endothelial growth factors, placental growth factor, and the antagonist for that is the soluble fragments like tyrosine kinase, SFLT1. Okay, so this is the culprit. This one will reduce the levels of these growth factors, which results in the improper plantation and also the endothelial defects. So this is the stage 1. This picture will tell you. This is the myometrium. This is the bilateral covering layer called the decidua, and this is the placental trophoblastic cells which have to grow from the fetus side. So when they go there, this is the spiral artery. The spiral artery, these dark lines are the muscle coat. So in a normal pregnancy, all that muscle coat is removed. So what happens when the blood vessel almost becomes like a simple tube with no muscle coat. So all the maternal blood flowing from that will be actually more amount of blood will be able to travel to the placenta. Whereas if you have the muscle coat still intact, as happening in preeclampsia, the volume of blood flowing is very much reduced. So the placenta is always remaining ischemic. And this is the failure of the trophoblast. So these are the trophoblastic cells which have to go invade and then remove this muscle coat. That is not happening in preeclampsia, whereas this is the normal way it should be happening. And the conversion of the small caliber spiral arteries into a capacitance vessels from a resistance vessel. Okay, so when the muscle coat is there, they are able to contract and relax like a normal vessel. Whereas once the muscle coat is removed, it becomes only a conduit or a large caliber capacitance vessel. That is the main change that you have to remember. And then this is the various cytokines and pro-inflammatory and anti-inflammatory cytokines which are there taking place, causing the endothelial dysfunction. So this is the, you can see here the soluble fragments like tyrosine kinase 1 combining with vascular endothelial growth factor decreases their action. Both the vascular endothelial growth factor and the PVAG are all reduced. And then there is a inflammatory cytokines like tumor necrosis alpha, interleukin 6, all these things. So they produce more of reactive oxygen species. Then nitric oxide production is also very much affected. Nitric oxide is important for the validation. So there are three mechanisms are there. One is the SFLT, second is the DNF alpha producing reactive oxygen species and oxidative stress, and third is the inhibition of nitric oxide. So all these things result in the endothelial dysfunction. The endothelium also, the capillaries become leaky. So the net effect is vasospasm in some areas, capillary leak, and activation of coagulation. These are the three basic changes that happen: vasospasm, capillary leak, and activation of coagulation. Again, this is a two-stage clinical process. The timing, it can happen before 20 weeks, start from that time onwards. Sometimes it can happen little later also. That is why you have to wait for 20 weeks to brand the patient as pathophysiology as preeclampsia. Sometimes it can happen little late, and inadequate invasion is the main reason if it is going to happen before 20 weeks. Whereas after 20 weeks, when it suddenly comes, it is oxidative stress and hypoxic placenta, generalized systemic inflammatory response released by the anti-angiogenic factors and inflammatory cytokines. So in the last slide, we saw three mechanisms. So the late occurrence of preeclampsia is due to the second mechanism of reactive oxygen species reduced more in number. It is like an oxidative stress condition. And so some people classify preeclampsia into early onset preeclampsia, EOPE, occurring before 34 weeks of gestation. It is thought to be primarily caused by this enterotrophoblastic stress leading to poor placentation, whereas late onset occurring after 34 weeks is found to be secondary to placenta outgrowing its own circulation and producing a lot of oxidative stress. So EOP is associated with fetal growth restriction. So if the IUGR, intrauterine growth retardation, if it is present, you can be very confident that it is a early onset preeclampsia. On the contrary, if the fetal growth is normal, it is mostly the late onset preeclampsia. And the grades, previously they have made the grading according to the blood pressure. It can be mild when it is 140 to 149, systolic 90 to 99, moderate 150 to 110, severe above 160 to 110. And symptoms are associated usually with severe preeclampsia. But this classification is now has been replaced by another classification, that is preeclampsia with mild symptoms, preeclampsia with severe symptoms. That is the two categories under which is not anymore based on the blood pressure. So patient's clinical symptoms are very important. So a patient may have a BP of 180, 120, but if they don't have headache, if they don't have visual, this will considered as a preeclampsia with little or no symptoms. So we no longer classify them based on the BP, and we call them or give them credence only based on the clinical symptoms of the patient. So the patient, what are the symptoms they may have? They may have headache, visual disturbance, upper abdominal pain, nausea, vomiting, sudden swelling of face, feet, and hands, and the tendon reflexes will become very brisk. So all these things are the clinical features. And what are all the systems that are affected in these cases? Neurologically, they may have thrombocytopenia. Platelet will be low in count. Altered coagulation will be there. And they can present as HELP syndrome. And biochemically, the kidney will have urea, creatinine, sodium, potassium, all can get haywire, and increased serum urate will be there. Proteinuria, elevated urine protein creatinine ratio, liver, low albumin, low glucose in severe cases, elevated liver enzymes, AST, LT will be elevated, and LDH also will be elevated, and bilirubin levels will go up, especially in HELP syndrome because of the hemolysis, bilirubin level also will go up. And if you do the full blood count, there will be, you have to insist on platelet count, and then clotting screen should be done, LFT should be done. Request for a peripheral blood smear if you find hemolysis as a component. Urea and electrolyte, you have to see the serum creatinine, urate, liver function, kinases. Then urine, this is the dipstick feeding. So when you have trace, your protein excretion is 0.1 to 0.2. Plus 1 plus in 24 hours, you will have to have 0.25 to 0.5. 2 plus, 3 plus is our case, what we are discussing. So 2 to 5 grams, the range is the protein level. And urinary protein creatinine ratio from a random sample also is important. And the proteinuria is more than 30, we will not confirm or quantify the proteinuria. And 24-hour urine collection also will confirm the total quantity of protein excreted. Midstream urine to exclude infection. And the urine output is a very important monitor that you have to keep in account because they can develop renal failure. And ultrasound is used in all these cases as part of investigation for airway assessment, gastric volume measurement, vascular access, lung fluid assessment. Early pulmonary edema can be easily diagnosed with the ultrasound, and optic nerve sheath diameter measurement for any cerebral edema. And in patients who have a lot of swelling in the back, you find it difficult to palpate the bony landmarks for a neuraxial block, either epidural or for spinal. Can use ultrasound. So there are 6 advantages or purposes for which you can use ultrasound: airway evaluation, gastric volume measurement, vascular access, either central access or peripheral, and lung fluid assessment, optic nerve sheath diameter measurement, and neuraxial blockade. And there is something called RO scan, where rapid obstetric screening echocardiography can be done, especially if the left ventricular function is not all right. Then you can do it as a transthoracic echo to assess the fluid status of the patient. So you will find the ventricles are pretty much contracted in spite of the edema the patient may have. The fluid status, if they are chronically intravascular contracted, even though blood pressure is high. Coming to the factors associated with the development of preeclampsia, pregnancy induced can happen in first pregnancy or the multiparous woman also. Then there is a donor insemination, that is artificial. Nowadays we know the patients undergo fertility treatment. So one of the methods is the donor insemination. polar pregnancy, chromosome abnormalities, and then maternal can happen either older to 35 or lesser than 25. Both age groups can get affected. And there's a family history of mother, sister, even sister-in-law, they say, daughter-in-law also can get affected. Putting diastolic blood pressure of 80 millimeters or more, associated diabetes, obesity, or chronic hypertension, renal disease, smoking, in the mother, all these things can lead to preeclampsia. And congenitally, they may have antiphospholipid antibodies or factor V Leiden and SLE. Maternal first-time father may be the cause for this. Life-threatening complications of preeclampsia are hypertensive crisis, pulmonary edema, and eclampsia. These are the three life-threatening complications. And this SIBI's criteria is to identify whether it is a true or a complete health syndrome. So these tests will tell you about the whether it is a true health syndrome or it is abnormal peripheral blood smear, where to identify hemolysis. And because hemolysis happens, bilirubin starts increasing, and the LDH also goes up, and the liver enzyme level, AST also goes up, platelet count drops to less than 100,000. So if these five findings are there, it is a true or complete health syndrome, which is called the SIBI's criteria. And the complications are maternal complication, cardiovascular, localized vasoconstriction, and decreased circulating volume. They are volume contracted or volume depleted. Left ventricular failure may be there because of the increased vasoconstriction. Okay. So the so-called afterload will increase. Left ventricular failure can happen, and congestive failure also can happen. The nervous system, they can have headache, visual abnormality, rheumatic confusion, hypertension, and cerebral hemorrhage is the cause for death, severe hypertensive preeclamptic women. Convulsions can happen because of cerebral irritability. Respiratory system, generalized edema with enhanced upper airway edema. So airway examination is a very, very important thing that you are planning GA, you have to plan, examine the airway, upper airway, as well as look for features of pulmonary edema. And non-cardiac pulmonary edema because of the capillary leak. So even with the pressure being normal, sometimes they can develop a pulmonary edema. Coming to the renal system, glomerular capillary endotheliosis and microthrombi can happen. There is a reduction in GFR, reduced urea clearance, and proteinuria and hyperproteinemia can happen. And oliguria and acute renal failure, because they are volume contracted, they have to watch out for the secretion. The liver, they can have abnormal liver function tests, subcapsular hemorrhage, which is the cause of mitochondrial pain. Pathology, they can have anticoagulation, less turnover of mitochondria and fibrin, thrombocytopenia, and platelet dysfunction. DIC is one of the important complications which can kill the patient. That was health syndrome. Fetal complications, decreased placental perfusion. Early stages, it will cause uterine growth and fetal growth retardation. And placenta can become ischemic and infarcted and can get separated at any time. So disruption or placental abruption is very common. The babies may be small for the date, and placental preterm labor is another important risk. All these complications are more in early onset preeclampsia, that is EOPE. What are the controversial areas in the clinical management? The preeclampsia develops at early gestation. When and how should be tackled? When is invasive monitoring needed? You need an invasive monitoring. That is, patients who have very high BP and who come for interventional surgery. They have already some features of mild pulmonary edema, edema. And all these patients, more the complication, more invasive monitoring will be. And benefits and risks of various antihypertensives, which which one will be the better one, which is the safer one, but the other controversial area. How should we manage an epileptic seizure? Whether you should give anti-epileptics or only magnesium sulfate is another area of debate. And why magnesium is preferred over anti-seizure medication? What are the safety issues with magnesium? And how should we manage fluids? Whether you have to give colloids or crystalloids, large doses or small doses, these are another controversial issue. Platelet count is the platelet count value which you can give safely neuraxial blockade. And the spinal safe in severe preeclampsia. During our student days, they used to teach us only GA for preeclampsia because they were scared that once you give spinal, the BP will crash and patient will die on the table. But a lot of studies have now proved that it is not so. The BP does not crash that drastically, so you can manage even for the category 1 cesarean section. You can give spinal safety in preeclampsia. Lastly, should the phenylephrine replace ephedrine to treat hypertension? This is another issue. Many people say that phenylephrine is a better drug because it is a selective alpha blocker, agonist. Management strategies. The only cure for treating the preeclampsia is delivery of the baby and fetus. So you have to plan for early delivery if all the things are okay. And the second consideration is whether you have to save the mother or save both, or you have to avoid prematurity in the baby. This is the second thing that you have to remember. So gestational hypertension with mild preeclampsia, you can manage the patient at home with frequent monitoring and fetal surveillance. So there is no need. If it is only a gestational hypertension with no proteinuria, patient can take antihypertensives and be at home and come for frequent checkup again to the patient. Similar to the same thing with mild preeclampsia with moderate elevations in BP and no clinical features in the cardiac or blood information. Whereas severe preeclampsia cases only need admission. So favorable cervix with adequate fetal maturity, that is after 36 weeks, anytime the patient can undergo retection with proper pain relief. So if the cervix is likely to dilate and the baby is more than 36 weeks, you can easily induce labor. The physician can do that, and you have to give epidural anesthesia for pain relief. If the cervix is unfavorable, it is not dilating, and fetal maturity should be if it is more than 36 weeks, then you can go for elective LSCS, not emergency. You can plan for an elective LSCS. And less than 34 weeks with severe preeclampsia, delay delivery for 48 hours, mainly to administer steroids and achieve lung maturity in the baby. That is the only reason for which you can delay that. But at any time, if there is a risk to the mother, you have to immediately go for surgery. So mother's life always precedes the safety and the post-delivery problems of fetus. So fetus becomes secondary. Mother is the main patient to be saved. So that is the most important message that you have to take. Magnesium sulfate infusion and IV antihypertensives are used for BP when there is more than 170/110. HELP syndrome, treat with large doses of dexamethasone 10 mg BD, even for the mother. It is not for the lung maturity of the baby, it is for the safety of the mother. You have to treat the mother with the dexamethasone. Now, how do you manage the hypertensive crisis? Most important dilemma in hypertensive crisis is maternal complication prevention versus fetal safety compromise. These are the two things which have to be balanced. So whether you have to prevent the complications of the mother or do you have to safely deliver the baby. So high maternal BP, the chances or pulmonary edema and cerebral hemorrhage are the two life-threatening complications which we already saw. So high systolic BP causes cerebral bleed and stroke. Invasive monitoring rarely needed in most or young patients with fewer chronic illnesses. This has been the finding with many studies. So unlike the complicated cardiac patients or other elderly patients, invasive monitoring is very rarely needed in pregnant mothers. But arterial line will be useful in case the patient is admitted with a hypertensive crisis. So consistent BP of more than 160, 110 who are on IV vasodilators, you have to put in an arterial line. Those who have coagulopathy and need frequent samples, there also very safely you have to do an arterial line, but with more care. Those who are obese and very severely edematous, where blood pressure measurements may be erroneous, we have to go for arterial line. And if there is pulmonary edema and frequent ABG is needed, again arterial line is indicated. So sometimes the examiner may ask you indications for an arterial line in an eclamptic patient. These are the points that you have to remember. Management of hypertensive crisis continuing. A CVP or a PA catheter is not normally used because of the complications of bleeding, and you need trained people to manage that. But it may be indicated if there's a congestive cardiac failure or a pulmonary edema with a large alveolar arterial gradient, and if there is a oliguria despite fluid registration, then you have to go for a fetal line. What are the drugs used for management? Oral drugs for regular hypertension with not much of a symptoms. You can go. Early drug was methyl dopa, but nowadays very rarely the physicians use this. The side effects why it has become unpopular is postural hypertension, sedation. Some patients become depressed. There can be bradycardia, headache, hemolytic anemia. The contraindications are liver disease and increased postnatal depression. Early in pregnancy, if the mother had the postnatal depression, do not give methyl dopa during the next pregnancy. Labetalol is the drug of choice. It is available both as a oral route as well as the parenteral route. So orally, you can give from 200 to 1600 milligram in divided doses. IV, you can start with 50 milligram bolus and titrated by infusion. Its mode of action is a combined alpha and beta antagonist. The ratio of alpha to beta is 1:3 for oral and 1:7 for IV. That is why it's more effective as an IV drug rather than an oral drug. Side effects are bradycardia, fatigue, bronchospasm, and gastrointestinal disturbances. Contraindication, asthma, cardiac disease, and phlebotomy. Continuing with the drugs, hifedipine is one of the drugs which is commonly given oral route by 20 to 90 milligram. You have to avoid sublingual route. And calcium channel antagonist, the mode of action, it blocks the entry of calcium. And headache and dizziness, tachycardia, flushing, side effects, contraindication in aortic stenosis and liver disease. Hydralazine is available as a IV only, 5 milligram bolus followed by 5 milligram every hour. Mode of action, the activation of guanylate cyclase with the intercellular cyclic GMP leading to increasing intracellular calcium causing vasodilation. Side effects, of course, fluid retention, flushing, palpitations, all these things are there. Contraindications, the patient has severe tachycardia, you should not give hydralazine. Continuing the thing, sometimes alpha blockers, perfusion also is used. It's a highly selective alpha-1 adrenergic receptor. This drug is used as the BHP also, benign hypertrophy of the prostate for reduction of the size of the gland. Perfusion is used. Side effects are syncope, headache, and postural hypertension. Contraindication, it is not teratogenic. So AC inhibitors and ARBs are not at all recommended for pregnant women, especially during the first trimester because they are highly teratogenic. So you won't find any recommendation for these drugs in pregnant ladies. Beta blockers, beta adrenergic receptor antagonists, they can cause bradycardia and neonatal hyperglycemia. Contraindications may be can cause IUDR, and so preferably better to avoid them as a first line of drugs. And diuretics, if the patient is in severe edema or other pulmonary edema, then you can give diuretics. But the early stages, it can cause neonatal thrombocytopenia. Contraindications, they don't cause any fetal malformations, but generally avoiding pregnancy and even the physiological volume expansion, which will be avoided and reduced if you give diuretics. Magnesium sulfate, everything, all the points you should know about it. So given by IV route only, 4 gram bolus over 10 minutes, followed by 1 gram infusion for 24 hours or 0.5 gram in patients. So before starting magnesium sulfate, make sure that what is the urine output of the patient for 24 hours. Then only you should start. Similarly, you must check the potassium level. Also make sure that the patient does not have myasthenia gravis problem. Further bolus of 2 to 4 grams over 10 minutes if seizures can occur. If any of the eclampsia, you can anytime you can give a supplementary dose of 2 to 4 grams. The mode of action, if the antagonizes the calcium channels, reducing the systemic and cerebral vasospasm. The same effect at the neuromuscular junction, it prevents the entry of calcium into the presynaptic area, so acetylcholine release is inhibited. Similarly, at the postsynaptic level also, it desensitizes the receptors to acetylcholine. It is also acting as an NMDA antagonist, which is the main reason for its anticonvulsant action, and increased production of endothelial prostacyclin, restore thromboxane prostacyclin imbalance. And the side effects of therapeutic range is 2 to 4 millimole. After that, first thing to be lost is the deep tendon reflex. If you do a knee jerk, that will be very sluggish. Then patient will complain of blurred vision. Then the patient will go for respiratory depression. At 10 millimoles, cardiac arrest will happen. So clinically, easy to find out by doing the knee jerk and asking the patient for any blurring of vision and counting the respiratory rate. These three are very, very easy clinical method of assessing the blood levels of the magnesium without waiting for the sample to get the results. Contraindications and causes. In case of cardiac arrest, stop infusion, start CPR, give 10 ml of 10% calcium glutamate. Send magnesium level urgently to the lab to assess the level. Care when using nifedipine as they interact synergistically. So whenever the patient has taken nifedipine starting magnesium, better to adjust the dose. Magnesium crosses the placenta, leading to neonatal hypertension and respiratory depression. So you have to be very watchful. And prevention and control of seizures. IV magnesium sulfate 4 gram bolus over 10 minutes, followed by 1 to 2 gram till 24 hours post delivery. The maintenance dose is stopped or decreased to 0.5 if the patient is alleviating or if the serum magnesium levels seem to be going up. The event of seizures, a further dose of 2 to 4 gram can be given. If further seizure occurs, despite the increasing or repeating the dose of magnesium sulfate, inform the intensive care for additional seizure treatment and airway support and ventilation. 44% of eclamptic fits occur after delivery also. So postnatal vigilance is very, very important, although the disease will resolve spontaneously. Control of seizure. The steps are: first, administer high flow oxygen, turn the patient to full left or right lateral decubitus position. Introduce a right block carefully as the patient may be making the panel. Suction and clear the secretions from the upper airway. Small doses of tapentone and perfusion can be given along with magnesium sulfate. Additional 2 grams of magnesium CT MRI if seizure is recurrent or there is a rule of cerebral hemorrhage. So if the patient gets repeated attacks of eclampsia, fit, we have to order for a CT and MRI. Or if the patient is not completely oriented, conscious after an eclamptic or fit attack, you have to think of cerebral hemorrhage and do a CT MRI. Consider delivery by either if the patient has had only one episode of fit and fully recovered and conscious, you can even induce labor and then go for a labor epidural and then deliver the baby, or plan for a operative delivery. Fluid management is another important challenge. What are the changes that happen is contracted vascular free, causes contracted blood volume, sudden vasodilation, if vasodilators are given, will cause a severe drop in BP. The second thing is leaky capillaries, causing pulmonary edema, compounded by reduced plasma albumin due to dilation proteinuria. So it's always safer to err on the side of less fluid intake. That is why magnesium is also not diluted in a larger volume. This is the reason why I asked that question. Maintenance fluid intake, including all IV infusion, should not exceed 1 ml per kg per hour. Always watch out the urine output for at least 0.5 ml per kg per hour. And even if it's not being monitored continuously, at least 2 ml per kg over 4 hours is also accepted. So even if 1 hour urine output is there is no urine output for 1 hour, don't get worried. Watch for 4 hours, and during this 4 hours, if there is more than 2 ml per kg, that is accepted minimum. And co-loading is preferred to preloading. Never give preloading of IV fluids before spinal. Always keep it along with the spinal. So co-loading is safer. Coming to the delivery management, time and mode of delivery is dependent on the severity of the condition and gestation of the fetus. So maternal preeclamptic severity and the fetal maturity. These are the two factors to decide when to deliver the baby. The decision to deliver depends largely on the maternal rather than the fetal well-being. So maternal life, mother's life is more important than the baby's life. So that is the dictum that you have to follow. Anesthetic considerations. Choice of anesthetic technique for cesarean delivery depends to a large extent on individual circumstances, though a regional technique is preferable in most cases. So remember the point that regional is not totally contraindicated. You have to decide and choose which depending upon the condition, but it is not a total taboo. Hemodynamic stability following a spinal anesthetic was comparable to epidural blockade also. So even if it is a subarachnoid block, patients were hemodynamically stable. So previously we were taught that only epidural will cause a slow drop in blood pressure, so you can easily manage. But here in preeclamptic patient, even subarachnoid blocks are not that much vulnerable to cause a hemodynamic instability. Subarachnoid anesthesia in women without an epidural in situ, spinal or combined spinal can be done. Nowadays we have that advantage of doing a spinal combined spinal epidural. So that is another choice. Coming to epidural anesthesia, the advantages are it helps to control the BP, improves placental blood flow, abolishes labor pain, can be extended to provide operative anesthesia, post-operative anesthesia also. The disadvantages are not suitable in patients with low platelets, so it's a contraindication. More chances of hematoma formation, even in patients who have a normal platelet count. Coming to general anesthesia, what are the indications to choose is only because of the coagulation abnormalities, which are contraindicated in regional recipients. So if the platelet is low and abnormal coagulation, better to avoid regional, so you have to go for GA. And post-ictal patients, that is patient who threw a fit and who has not regained full consciousness, or patients who get repeated attacks of seizures, it is better to go for general anesthesia. And if there is a pulmonary edema already associated and it is associated with hypoxemia, it's better to go for general anesthesia. And if the patient refuses any regional technique, this is the common class for any patients. Whenever any regional technique has to be practiced, patient has to accept. They refuse, you cannot pressurize that. Pressure response laryngoscopy can lead to dangerously high silent blood pressure that may lead to intracranial hemorrhage. So you have to be very, very watchful. So measures to attenuate this response are, you can use magnesium itself as a bolus to control this, or you can give labetalol 25 to 50 milligram, or you can use potent parenteral opioids, especially alpha-10, you do not have it textbooks, but our setup we don't use that. And we don't normally give any opioids before the baby's delivery. And we talked about induction delivery interval also. Antacid and antiemetic premedication, that is ranitidine metoclopramide, should be administered. Antihypertensive and anticonvulsant drugs should be continued if they are already on such drugs. Intubation may be difficult, so you have to be prepared for a difficult airway. And decreased pulmonary compliance may impair ventilation. If the lung fluid is high, that may cause impaired ventilation. If the woman has received magnesium, you have to titrate the muscle relaxant carefully using a neuromuscular monitor. So, ergometrin, I don't think anybody is using nowadays, or symptometry must be totally avoided. And symptocinone also is the only drug which can be given safely. And non-steroidal anti-inflammatory drugs to be avoided. So, normally we give this Gestational, diclofenac, 75 milligram, we normally give for all patients. That should be avoided because it can affect both the kidney and the platelet function. Paracetamol may need to be withheld if there is laboratory evidence of liver dysfunction. So, routine use of paracetamol be carefully thought of, because the liver values are normal. You can give paracetamol as a painkiller, but not in cases. What are the allied topics you have to learn for exam purpose? Physiological changes during pregnancy, anemia complicating pregnancy. Suddenly they may ask you, unless this patient is anemic, what do you do? They can drag on to completely anemia complicating pregnancy. Then they can ask you all the steps of management, of anesthetic management for elective and emergency is there and how it varies. Management of antepartum and postpartum hemorrhage, that may be the topic that can be diverted upon. Labor analgesia, all the details about that. Clinical resuscitation. So when a large group of students are appearing in the examination, as I repeatedly say, examiners will be bored of asking the same question. So they can divert it to some other topic. These are all the allied topics you have to know. Placental circulation, the physiology. So these are all the points that I wanted to share with you. So, shall we do?
Yes, sir. Will ask the students, sir.
Next week.
Yes, sir. The respiratory system, I think we are having 12 participants in all. 11 as of now.
Okay.
And already this is a big topic.
So it's possible to cover. We can't do justice to all the questions. So that's why we prepared the PPT so that they will have an idea about the as well as how to answer the examination.